Hi, good evening. My name is Monique Hill, and I will be producing tonight's webinar. It is brought to you by Texas Fertility Center, and our guest speaker today is Dr. Hansard, and we are talking about minimally invasive surgery for infertility. We're so glad that you could join us tonight, especially during such a busy time of year. And I just wanted to get some administrative things out of the way while we wait for a few more people to join. If you'd like more information on upcoming webinars, we do these the third Thursday of the month. We do have one coming up in December. That one will be Do I Need IVF? And then in January, we will have one on, it's an IVF orientation. And then if you go to the website, there are a list, you can go to the events and you can see what other websites or what other webinars are going to be coming next year. You can go to txfertility.com to get that information. Now, before we get started with our speaker, I want to let you know that we will be stopping halfway through to allow you a chance to ask questions, and Dr. Hansard will reply to those questions. I'll ask them to her. And then at the end, there will be another opportunity for you to ask some questions. So if you look on your top right part of your screen, there's a spot that says questions. Feel free to submit your questions there, and I'll be asking those to Dr. Hansard. And I do want you to know that your information is confidential. So please feel free to ask what you're comfortable asking, and your information will not be disclosed. And I think that's it for now. So I would like to introduce you to Dr. Hansard, and I will be back halfway through.
Thanks, Monique. So our topic tonight is surgical treatment of infertility. And it's interesting that a lot of times when people ask, what do you do? And I say, I'm a fertility specialist or I'm a fertility surgeon. They say, I'm confused. I don't know what that means. I thought that fertility care was just in vitro fertilization. And I have to explain that that's not necessarily the case, that there are a lot of medical conditions that can lead to infertility, and that sometimes it's a simple surgical fix to improve the chances of conceiving naturally. So what I'd like to talk to you about is a little bit of the basic workup for infertility and why there are often recommendations to pursue fertility enhancing surgical options for improvement in chances of succeeding in achieving pregnancy. So what we know is that when couples try to conceive, approximately 50% of couples get pregnant within the first 3 months of discontinuing contraception, and another 75%, or total of 75%, are pregnant within 6 months. At 1 year, it's 85%. So if you meet the criteria for evaluation of infertility, one of the things that will be tested is the patency of your fallopian tubes. So a study called a Hysteroscopic, or HSG for short, is a very common initial treatment or recommended diagnostic study for infertility. This study is performed typically by a radiologist at a specific time in a woman's menstrual cycle, which is after her period is over, but before ovulation occurs. The patient goes to the radiologist's office. They set her up like she's going to have a pap smear, put a small catheter through the cervix, and inject dye through that shows up in an x-ray. And that dye will show if the uterine cavity is normal and if the fallopian tubes are open. If that study is normal, then we typically move to a transvaginal ultrasound or sonogram. This is done at various times in the cycle, and basically it's looking for multiple things. Whether or not there's any uterine pathology, predominantly a uterine fibroid, which is a benign muscle tumor, or a polyp, which is an overgrowth of the endometrial lining inside the uterine cavity, or if there's any ovarian pathology, like an ovarian cyst that has characteristics of pathology such as a dermoid tumor or endometriosis. If either the HSG is abnormal, showing a tubal or uterine anomaly, or If the ultrasound shows ovarian pathology or a fibroid, the recommendation may be to undergo a minimally invasive surgical procedure to improve the anatomy. And the goal here is really to just restore normal structural integrity of the reproductive tract, to potentially allow for natural fertilization and pregnancy to occur. So we'll discuss some of the different findings from our diagnostic testing and what the approach would be for treatment and evaluation. If, for instance, a hysterosalpingogram shows tubal occlusion, where the fallopian tubes do not either fill with the dye or spill the fluid into the peritoneal cavity, then the next step would probably be either a diagnostic laparoscopy or a repeat procedure. Now, some of the factors that could lead to tubal occlusion would be, for instance, a history of pelvic inflammatory disease or symptoms consistent with endometriosis, which we'll discuss a little bit more in detail. So if, for instance, the hysterosalpingogram or HSG shows tubal occlusion where the uterus and the tubes meet, the question is always, is this real, or might this represent tubal spasm or a mucus plug or something that can be mechanically cleared to allow for that tube, fallopian tube, to function properly, to pick up an egg, transport sperm, and provide the normal environment for embryo development. So the next step with tubal occlusion would be a laparoscopy. So laparoscopy is an outpatient, minimally invasive surgery that does involve a general anesthesia and an incision in the umbilicus or the belly button. Through the belly button, we place a telescope type of instrument called a laparoscope. This is attached to a camera, which is then attached to a large monitor. So on a big screen, we can see everything that is happening inside the pelvis through approximately a 1 centimeter or half an inch incision in the belly button. We inflate the abdominal cavity with carbon dioxide gas to be able to see an airspace and see the structures. And then through the vagina, we can place a catheter into the cervix where we can place a fluid which will go through the uterine cavity and through the fallopian tubes to show whether or not those fallopian tubes are open. This procedure is called chromopertubation. And if it is negative, in other words, if it shows true tubal occlusion at the junction of the fallopian tube and the uterus, then there is a secondary procedure that can be performed through the uterine cavity. I want to stay for a moment and talk about laparoscopy and the other conditions that laparoscopy can diagnose and treat. The most common one is endometriosis. Endometriosis is a very common fertility condition. Endometrium is the tissue that normally grows inside the uterine cavity that women shed every month when they get their period. Osis, as a suffix, means abnormal location. So endometriosis is endometrial tissue growing in an abnormal location. The most common place that we see this is in the pelvis, and that can be behind the uterus, on the fallopian tubes, involving the ovaries, etc. The question is always, how does endometriosis impair fertility? If my fallopian tubes are open and I'm ovulating, why would endometriosis have an impact on the chance of my conceiving? And the answer is, well, that's the million-dollar question. So there are scientists who have spent their entire careers studying endometriosis and its impact on fertility and why it has a negative consequence. And the answer is, we're just not really sure. But we do know if we can diagnose endometriosis and we can treat it, then the chances of getting pregnant with any measure, even just spontaneous attempts with timed intercourse, are improved. So the problem with endometriosis is that it affects probably about 35% of women in the reproductive age group. So we will find this as a fertility condition in a not insignificant number of our patients. No one knows why some women develop endometriosis and other women do not. What we do know is if it's diagnosed and treated, then the pregnancy rates are improved over the course of the next 9 to 10 months. Now, they're improved relative to not ever having treated the endometriosis. But we never get someone back to the same level of fertility as someone who never had endometriosis to begin with. So it's an improvement in the outcome, not a cure. And whatever it is about a woman that causes her to develop endometriosis in the first place, we don't change that. We can treat the disease that she has, but we can't change what it is about her that made her develop endometriosis in the first place. One of the things that increases the likelihood of endometriosis is a prolonged amount of time without a pregnancy and with no contraception. The other thing, and probably the most important thing, is a family history of endometriosis. So we know that this is something that often occurs between siblings or between sisters or among a mother and her female offspring. So there's a lot we don't know about endometriosis, but it is a very, very common reproductive condition. The most important and maybe frustrating aspect of endometriosis is there really is no way to diagnose this condition other than with a laparoscopy. So many, many women, when we're talking about this whole evaluation, saying where does laparoscopy fit into the diagnostic testing algorithm, is women will say, well, I have a girlfriend and she has endometriosis. And the reason that she was diagnosed is because she had very, very, very painful periods. And her doctor said, you haven't responded to birth control pills or other medications. We need to do a laparoscopy to make this diagnosis. My answer to that is that sometimes women who have endometriosis, and even the most severe cases of the disease, don't have any symptoms like that. The only symptom they have is infertility. So it's a very challenging condition to diagnose and to treat, because some women who have just one or two very minor implants of disease have really debilitating symptoms. And the main symptom is pain and cramping at the time of the period that progresses over time. However, there are other women who have really just very terrible disease, what we consider stage 4, involving the fallopian tubes, the uterus, sometimes the bladder, the intestines, the ovaries, and they can have absolutely no symptoms at all. Normal cycles, everything seems fine. So we still keep this as a very important part of our diagnostic armamentarium. So hysteroscopy, going back to that. Hysteroscopy was designed to look at the interior of the uterus, and to also potentially be an asset in opening fallopian tubes if the fallopian tubes are otherwise normal. So diagnostic laparoscopy evaluates for endometriosis. It evaluates for tubal patency, whether or not the tubes are open, and it also looks at if there's any scar tissue. Now, scar tissue could be from a previous pelvic infection, pelvic inflammatory disease, most commonly caused by chlamydia or gonorrhea. Unfortunately, at least 50% of women who have pelvic inflammatory disease and scar tissue or blocked tubes as a result of that have absolutely no idea when they were infected with one of these organisms. And they may have just thought, well, I had an intestinal bug or had a fever, I had pelvic pain. I thought it was just a stomach flu. And in fact, that this actually represented a pelvic infection that resulted in tubal disease and tubal damage. So a laparoscopy will also tell us those things. And the treatment is often with laser ablation or cauterization of the adhesions, which is scar tissue, or endometriotic implants. Endometriosis, however, will be a recurrent disorder. So if you are diagnosed with endometriosis and it's treated, then typically we say you've got the next 9 to 10 months to try to get pregnant, utilizing the fallopian tubes in the pelvic environment before needing to talk about other interventions such as IVF, in vitro fertilization. So hysteroscopy is another procedure where the telescope that we talked about with laparoscopy, there's a small telescope that goes through the cervical canal, so through the vagina, opening the cervix with genital dilation, putting a telescope into the cervical canal, attaching that to a camera, attaching that camera to a monitor. So again, through a large TV camera like we're looking at right now, we can see through a very small space, 1 centimeter. And hysteroscopy gives us an evaluation of the inside of the uterus. So the abnormalities that we can see through the cervical canal into the uterus would be things like endometrial polyps. These are overgrowth of the mucous membrane of the uterus. So just like some individuals grow polyps in their colon that require colonoscopy and surveillance and removal of those polyps, or polyps can also occur in the nasal or sinus passages, and they can be abnormal and even progress to precancerous lesions. The same thing can happen in the endometrial cavity. And we can diagnose this with either hysteroscopy or hysterosalpingogram. Occasionally we can see this with transvaginal ultrasonography or a procedure called a saline infusion sonohistogram. So if part of the fertility evaluation involves a transvaginal ultrasound, sometimes we'll see a shadow or a mass or a lesion inside the uterine cavity. If it's unclear, then we have several choices. We can either do a or minimally invasive procedure called a sonohistogram, where you come to the office, we put a small catheter through the cervix, inject sterile saline, and fill the uterine cavity with fluid. Fluid on ultrasound is black. If there is an abnormality, we will see that as a gray or a white mass within a black uterine cavity. That's diagnostic for a uterine abnormality such as a polyp or a fibroid, which is a benign muscle tumor that can arise in the uterine cavity. If we see this, then a hysteroscopy is the next step. So at hysteroscopy, we can not only diagnose abnormalities such as an endometrial polyp or a uterine fibroid or scar tissue from a previous surgical procedure such as a D&C, or a congenital abnormality, meaning something you were born with, like a uterine septum. All of those things can be diagnosed and treated with hysteroscopy, hysteroscopic surgery. Hysteroscopy is an outpatient surgery. That means in and out the same day. With hysteroscopy, there are no incisions, and the recovery is very, very rapid. Most women who undergo a hysteroscopic procedure are able to go back to work the following day without any downtime. The anesthesia for a hysteroscopic procedure is typically IV sedation. So this is anesthesia that's administered through an IV line with an anesthesiologist in attendance. It typically takes anywhere between 15 and 60 minutes, and there is no breathing tube. The patient is always breathing on their own. They wake up from the anesthesia very quickly and typically go home without any other consequences. There's no need for postoperative recovery. Usually the procedure is during the day of the hysteroscopy only, and they are able to return to all normal activities by the following day. Laparoscopy, the procedure we talked about with the incision in the belly button, requires a longer recovery period, typically 2 or 3 days off of work and minimal activity during those days. If these procedures are performed and fertility is improved or enhanced, then oftentimes there is no other further intervention that's necessary. Oftentimes at that point, we will say we will go back to timed intercourse using an ovulation predictor kit for anywhere between 3 and 6 months to see if spontaneous pregnancy will occur with nothing more than treatment of the anatomic abnormality. The one thing that I haven't discussed yet that I want to talk about a little bit more, and I'm going to take a break here in just a second for questions, is uterine abnormalities. So one of the things that we will see with either transvaginal sonography or with hysterosalpingogram is an abnormal uterine configuration where there may be either just one side of a uterine cavity, or a uterus that has a heart shape, or a uterus that's divided into 2 completely separate cavities. All of these have fertility ramifications. And so the diagnosis and subsequent treatment of these is very important. The main abnormality, which can be treated successfully with minimally invasive surgery, is a uterine septum. And this is basically a wall down the middle of the uterine cavity that separates the 2 sides of the normal space. The problem with that wall is that it does not have a good blood supply. So if an embryo tries to implant on any area of that wall, it may grow for a short amount of time, but once the placenta needs to acquire a blood supply from the uterus, then the growth and development of that fetus will be impacted and may even cause a pregnancy loss. It's the most common anatomic reason for a first or second trimester pregnancy loss or miscarriage. So the good news is, if a septum is diagnosed by ultrasonography or by hysterosalpingogram and resected, that means removed surgically, then the chance of the next pregnancy being successful and resulting in a term delivery has been reported to be as high as 85%, which is excellent news. I'm going to go ahead and open it up for any other questions that Monique may have right now, or any of our participants may have.
Thank you. Okay, thought I could have both of our screens the same size, but that's okay. We'd rather see you than me. For anybody that came on late, I would like to say, if you want to ask some questions, there's a tab that says questions. Please feel free to submit those questions, and your information is confidential, so don't worry about anything being disclosed. Okay, how soon after laparoscopic surgery can I resume exercise?
So this is an excellent question. So I said that laparoscopy typically has a recovery period of 2 to 3 days, but really the main determinant of when you can resume normal activities and exercise really is dependent on how you feel after you come out of the anesthesia. There's nothing about the surgery that's going to be dangerous in terms of my incision opening or causing increased harm to your internal structures. So I always tell my patients, as soon as you feel like you're ready to resume normal activities, whether that be exercising or sexual activity or going back to work, it's really all about how you feel. And the most important thing here is listen to your body. If you are feeling sore or tired or having pain, then the answer is always stop what you're doing and take a break.
Thank you. All right. What happens if polyps are left untreated?
So polyps may or may not be a problem. Polyps in the uterus are like polyps anywhere else. They have a low risk of malignant transformation, meaning the ability to transform into cancer. So particularly as women get older, when polyps are diagnosed, the recommendation is usually to have these removed, to have them evaluated by a pathologist to make sure they're not a precancerous lesion. In terms of their impact on fertility, there is definitely a risk for implantation failure, meaning a lower chance that an embryo will be able to attach normally to the uterine lining, or an increased risk of miscarriage if an embryo happens to implant in the area of a polyp.
Okay, there were a couple of questions with regards to these procedures being done in clinics or hospitals. One is, should I feel comfortable about a hysteroscopy done in the doctor's office versus at a hospital? And the other one is, are laparoscopies performed at a hospital or in the clinic? So is there a rule of thumb, are both performed in the clinics? What's your answer to that?
So laparoscopy is not performed in a clinic setting. Hysteroscopy can be, but hysteroscopy is typically only performed as a diagnostic procedure in a physician's office. So luckily, there is a very, very happy medium between the doctor's office and a hospital, and that is an ambulatory surgery center. So an ASC, or an ambulatory surgery center, is a medical facility that is designed specifically for outpatient procedures, with the intention being that a patient will show up, have a procedure, and be discharged the same day. The good news about an ASC is that these are the type of procedures that they are most suited for. So you're not exposed to a patient population that may be hospitalized for communicable diseases, obviously such as COVID right now, or people who are in the hospital for major procedures like cardiac surgeries or, organ transplant. So ambulatory surgery centers are a very, very successful and efficient way to have these minimally invasive procedures performed, because the whole idea is we're in and out the same day, and everyone's focus is on giving that type of acute care patient support. So the vast majority of these procedures are performed in an outpatient ambulatory surgery setting. That's a great question.
Yeah, that is. Thank you.
Yeah.
All right. So I had polyps. They have removed them and everything was normal. And also I've been told I have PCOS. So I've been trying for 5 years now and no luck. What do you recommend? And what do you think about IUI?
Okay. So that's a big question. First of all, endometrial polyps are actually more common in women who have polycystic ovarian syndrome. That's what PCOS is. And it's an ovulatory disorder. So because a woman who has PCOS doesn't ovulate on a regular basis, that uterine lining is allowed to grow and overgrow. And that is what puts that woman at risk of developing polyps. So someone who says, I have PCOS and have polyps, it's like, of course you do. That's typical. So IUI stands for intrauterine insemination, where we take a sperm sample from a partner, wash and concentrate the sperm, and then place it through the cervix into the uterus. If a woman has polycystic ovarian syndrome and an ovulation disorder where she doesn't produce an egg on a regular basis, our first line of treatment after the polyps were removed would be to initiate an ovulation induction protocol with a medication designed to improve ovarian function and ovulation. If ovulation occurs with these medications at least 3 or 4 cycles in a row with timed intercourse, and pregnancy still has not occurred, then intrauterine insemination would be a reasonable alternative. But if you're telling me or asking the question, polyps, PCO, IUI, I would say remove the polyps, treat the PCO with ovulation induction. If pregnancy does not occur, then intrauterine insemination would be a consideration.
Thank you. That's a great question. And so good to get your input on that. The order of things is always so important. My doctor told me I have pelvic adhesion. Would I be a candidate for laparoscopic surgery?
So pelvic adhesions is scar tissue. And scar tissue can be caused from any number of abnormalities or conditions. The most common reason to have pelvic adhesions in a young woman of reproductive age would be from a previous pelvic infection, such as pelvic inflammatory disease, or from a previous surgery or a previous pelvic infection, such as a ruptured appendix. Endometriosis can also cause pelvic adhesions or scar tissue. So if a woman has any of those conditions that I just mentioned, then it would be very likely that her physician would say, first steps, let's do a hysterosalpingogram. Remember that dye study with the catheter through the cervix to look at the uterine cavity and to make sure that the fallopian tubes are open. If the tubes are open, but there are other questions about scar tissue, then a diagnostic laparoscopy is in order. So when we talk about laparoscopy, and I may not have been clear about this, there's really 2 things about this. It can be diagnostic and therapeutic at the same setting. So we make the incision, we place the telescope, we look at the pelvic structures, and if there are any abnormalities, endometriosis, pelvic adhesions, endometrial polyps, tubal disease, then we have the opportunity at the same setting to treat all of these conditions with a combination of laser, resection, which means removal of the adhesions, and or opening the fallopian tubes with other surgical means. So diagnostic and therapeutic, but pelvic adhesions, absolutely, laparoscopy is an appropriate first-line intervention.
Great news. Okay, I'm going to ask you one more question, and then I'm going to disappear so you can finish up what you wanted to share with everybody, and I'll come back later.
Sure.
For now, the last question for this session here is, what are some possible reasons a saline ultrasound cannot be performed? I've tried having it done 3 times unsuccessfully.
So a saline infusion sonohistogram is a procedure that's done in the office for those of you who don't understand kind of the nuances of this question. And the way that it works is a woman comes into the office, she's prepared as if she's going to have a pap smear. We use an antiseptic to clean the cervix, and there's a small, very small, flexible plastic or silicone catheter that's placed through the cervix into the uterine cavity. Once this is accomplished, then the vaginal probe is placed into the vagina ultrasonographically, and then sterile saline is infused through the catheter. That sterile saline on ultrasound will show up as a black fluid. And so if there's any abnormality within the uterine cavity, it will show up as a gray or a white mass basically in a sea of black. And that's how we make a diagnosis of whether or not the uterine cavity is normal. So if a saline infusion sonohistogram cannot be performed, the most likely reason is because there is some kind of a stricture or closure or tightening or obstruction of the cervical opening. And so during a hysteroscopic procedure, for instance, a patient is asleep. And so if there is an occlusion or a narrowing of the cervical canal, it's easier to open that passageway without causing additional pain or discomfort to the patient because she's asleep. The most common reason to abandon a saline sonohistogram is because of patient discomfort. So the cervical canal may be obstructed, or it may be very, very tight, or it may take a curve a different direction that makes it harder to thread the catheter through. Some of the options for that would be to use a cervical ripening medication such as misoprostol, which is placed in the vagina anywhere between 4 and 8 hours prior to the procedure to help soften the cervix and make the opening easier to navigate. The other reason that a saline infusion sonohistogram may be impossible to perform is if there is scarring inside the uterine cavity. And the reason a uterine cavity would be scarred would be because of, the most common reason would be because of a previous surgical procedure, such as a curettage or a DNC resulting from a previous miscarriage, or for instance, a pregnancy that had a retained portion of a placenta that required removal. Anytime a pregnancy is complicated by an infection of the genital tract, that's going to increase the likelihood of having scarring in the uterus or the cervical canal. So I think that in this particular case, to answer this participant's question, it would be really important to have a full history. Is there been any evidence or any history of uterine surgery, uterine trauma, anything that would lead to cervical stenosis. And oftentimes we can approach a saline infusion sonohistogram with ultrasound guidance, where we can actually watch the catheter go through the cervix and see where the obstruction or the obstacle is. If that's the case, oftentimes that's easy to alleviate. But I would say the first step is, next thing would be, let's look at a cervical ripening medication. If that's not successful, then the next step is hysteroscopy to be able to access the uterine cavity without causing unnecessary pain or cramping or discomfort to the patient. Monique, are there any other questions?
Sorry about that. I thought that you were going to finish up whatever you wanted to present, but there are definitely some more questions if you want to.
Well, the last thing I was going to talk about, I'm trying to be very, very conscientious about our time. The last thing I want to talk about is uterine fibroids. So this webinar is about minimally invasive treatment of fertility. And one of the big things we haven't talked about, and big things we haven't talked about, is uterine fibroids. So fibroids are benign muscle tumors that are extremely common. And the risk factor for developing or growing these fibroids depends on several things. The most common thing would be a family history. So women who have other female members of their family who have had uterine fibroids are more likely to have one. African American populations are at higher risk of developing or growing uterine fibroids, and they just become more common as women age. So these are benign muscle tumors, benign meaning not precancerous, that arise from muscle cells that have started to divide and develop without any control. And so they usually form into a hard muscular ball of tissue. By the time a woman is 35 years of age, she has about a 35% chance of having a fibroid somewhere. So fibroids are all about whether or not they have an impact on fertility and or lifestyle, is all about Austin real estate, location, location, location. So depending on where the fibroid is will determine whether or not it has an impact on fertility and or just lifestyle. And by lifestyle, I mean a change in menstrual cycles that could limit or impact daily activities. So fibroids can be in various areas of the uterus. The most common one that causes a significant impact on both fertility and lifestyle is a fibroid that is submucosal, meaning inside the uterine cavity. And these arise from the muscle tissue that makes up the uterus. So if it's inside the uterine cavity, it not only causes a barrier to implantation and or a risk factor for miscarriage, but it can also cause heavy bleeding because it just grows and develops without any kind of hormonal response. And so one of the most common reasons to have bleeding throughout the menstrual cycle is a uterine abnormality like a uterine fibroid. The next location is called intramural, which means in the wall of the uterus. And there's a lot of disagreement and controversy about whether or not intramural fibroids are a factor in pregnancy. And the consensus seems to be that if a fibroid is smaller than 3 to 4 centimeters, so 1.5 to 2 inches in diameter, and it's in the wall of the uterus, it probably isn't a factor for fertility. That's still up for debate. And we would have to say the best thing to do is look at your individual situation and discuss that with your physician to see if this fibroid is clinically significant or not. The third location is serosal, meaning on the outside of the uterus. And those fibroids almost never need to be surgically managed. So the way to look at this is serosal, not an issue. Submucosal, inside the uterine cavity, almost always an issue. Intramural, it depends on the size and the location. So the way that we manage these fibroids depends on their size and their location. A submucosal fibroid that is predominantly in the uterine cavity can be treated with hysteroscopy, outpatient, day surgery, back to work the next day. A subserosal fibroid outside of the uterine cavity, unless it's really large, usually doesn't need to be addressed. The intramural fibroids are the ones that are really up for discussion. And if the consensus is that this is a fibroid that is either going to prevent pregnancy or have a negative impact on the success of a subsequent pregnancy and therefore needs to be removed, can be addressed any of a number of ways. The most common way is to open the wall of the uterus, remove the fibroid, and then repair the uterus. Depending on the size and location of the fibroid, this can be done through minimally invasive surgery or can be done through what we call a mini laparotomy with myomectomy. Laparotomy means making an incision in the skin. Traditionally, this is done in a C-section type of location, so low in the bikini line. The incision is made just large enough to remove the fibroid. The muscle of the fibroid is then reapproximated to close the space that the fibroid occupied. The surface of the uterus is closed, and then the internal layers as well as the skin are closed in what's called a subcuticular fashion. So this is a pretty common procedure that is performed, and it can actually be essentially an outpatient procedure. So the majority of the patients that I see that need a mini laparotomy with myomectomy can have surgery that morning, can be discharged by that evening, and usually require about a week or 2 weeks of significantly decreased activity. During the age of COVID, I've had quite a few patients who have had this procedure and they're already working from home. And so as soon as they are off of narcotic pain medications, which is the first or second day after surgery, they're back to work, at least on a part-time basis. So activity level is diminished for the first 2 or 3 weeks, and then regular activities can resume. So that's the last really hurdle anatomically that we can treat. And most women who have fibroids as their fertility issue, as long as they have normal ovulation, their partner has a normal semen analysis, and they have normal open fallopian tubes, removal of the fibroid may be all that is necessary to increase the likelihood of a successful pregnancy without further fertility intervention. So that's the last portion that I want to talk about, surgical management of fertility. So I'd like to entertain any other questions that we have, since we have another maybe 10 minutes left in our webinar session.
Thank you so much, Dr. Hansard. All right, here's one. I had a normal hysterectomy in August. Do I need a saline infused sonohistogram performed before embryo transfer next month?
So Great question. So patient has had IVF, has embryos, and is preparing for an embryo transfer with a normal hysterosalpingogram in August, so the dye study. And the question is, do we need a saline infusion sonohistogram prior to transfer? And unfortunately, you're going to hate this answer, but the answer is it depends. So every clinic has different parameters. We will at Texas Fertility Center, if the ultrasound evaluation is normal, and there's been a normal uterine evaluation, whether it's been a hysterosalpingogram, an HSG, or a saline infusion sonohistogram within the previous 12 months, then another uterine evaluation is not required prior to an embryo transfer. And good luck.
Can I skip laparoscopy and go right to IVF, or are chances of getting pregnant better if I have the laparoscopy first?
Wow, this is a great question. So this has become really interesting and a point of a lot of discussion in the last couple of years, because as more and more couples choose to pursue advanced reproductive technology such as IVF, the question becomes, where does a diagnostic laparoscopy fit in the workup of infertility? And it used to be that we would say 3 cycles of ovarian stimulation with intrauterine insemination. If you're not pregnant, diagnostic laparoscopy is the next step. And then pending those results, either revert to subsequent IUI cycles, or at that point, move straight to IVF. More and more insurance companies are covering IVF as a primary fertility treatment. And so unless there is a very obvious abnormality on HSG or diagnostic laparoscopy, such as, again, uterine fibroids or endometriosis involving the ovaries called an endometrioma, typically you can bypass the laparoscopy because IVF bypasses the uterine environment. And basically with laparoscopy, we're trying to just restore normal anatomy to let Mother Nature do her job more efficiently. If we're going to bypass that altogether with in vitro fertilization, then a diagnostic laparoscopy is not necessary. And having a laparoscopy and treating something like pelvic adhesions or endometriosis will not impact the chance of success from IVF. That's a great question.
Another one is, I had a normal HSG 16 months ago, and a pelvic ultrasound showed possible polyps. What is the likelihood of developing them in that time, or what else could it be?
Unfortunately, it's not low. So a normal HSG may be the worst, that's not true. It may be the least effective way of evaluating the uterine cavity. So clearly the best way to know whether or not the uterus is normal inside is with a hysteroscopy. The second best is with a saline infusion sonohistogram, and the third best is with an HSG. So an ultrasound showing a potential uterine abnormality would necessarily trigger either a saline infusion sonohistogram or a hysteroscopy. And in 16 months, absolutely a uterine abnormality could develop. Polyps are crazy. They can go from very, very tiny, maybe even not even diagnostic, to clinically significant in a course of 3 to 6 months. So an HSG 16 months ago, we wouldn't trust that.
That makes sense. All right. The last one is kind of two questions in one. How long after laparoscopy can I conceive? And how long after can I do, and/or how long after can I do IVF?
Okay, so this is a great question. Also, y'all are so good at all these questions. I'm so impressed. So the question of when can I get pregnant after I had a laparoscopy, right? So we usually perform a laparoscopy at a very specific time in a woman's menstrual cycle, which is after the period is over, but prior to ovulation. Because obviously we don't want to be doing a surgery with the general anesthetic on a woman who could potentially be pregnant. So I've had many, I'm old. I've been doing this a long time. So I've had many patients who have had a diagnostic laparoscopy and conceived in the exact same cycle of their laparoscopy. So if we're doing this procedure on, say, cycle day 8 or 9, we flush the tubes, we treat endometriosis or scar tissue. We say, hey, everything looks good. Use an ovulation predictor kit, try to conceive. I've had many patients conceive in the cycle that they had their surgical procedure. So we don't put a time limit and say, you can't try to get pregnant. In terms of laparoscopy prior to IVF, the situation that I'm thinking of that would make the most sense would be someone, say, for instance, who had a blocked fallopian tube or a fallopian tube that was full of fluid and destroyed, and they're saying, I have to do this prior to IVF. I've got to get my tube removed, so I'll be ready for IVF, or I have to get a polyp removed, so I'll be ready for IVF. You can proceed with IVF immediately in the very next cycle. And the recommendation is usually sooner is better than later.
Well, Dr. Hansard, that was the last question. And I thank you so much for your time. It's
well,
so
I appreciate
nice.
everyone participating.
Well, I just want to remind everybody we have one more of these in December. It's always the third Thursday of the month. And then again, we will start it again in January in the next year. So thank you so much. And I hope everybody has a wonderful Thanksgiving. And you also, Dr. Hansard, have a great Thanksgiving.
Same. You too, Monique. Thank you so much. And thanks everyone for joining tonight.